There is a spectrum of the Epstein anomalies, but the definition is that there is a dysplastic, displaced septal leaflet of the tricuspid valve toward the apex. As you may know, in a normal subject, for example, in this case, where this is a four-chamber view, left ventricle, left atrium, right atrium, and the attachment of the anterior mitral to the septum and the attachment of the septal leaflet, there is a distance or a gap between those two attachments. The tricuspid septal leaflet is usually more apical, so this is the apex and this is the base of the heart. And this distance should not exceed the 15 millimeters or should not exceed 8 millimeters divided by the body surface area. If this distance is more than the 15 or more than the 8, then this falls in the spectrum of Epstein anomalies. Usually the anterior leaflet of the tricuspid is tethered and very elongated. And of course, with a dysplastic displaced leaflet, this will cause tricuspid regurgitation, and in very rare cases, tricuspid stenosis. But in most of the cases, it's tricuspid regurgitation because of the dysplastic anomaly or the dysplastic displaced leaflets of the tricuspid valve. This would, of course, lead to, when there is a displaced leaflet, this would lead to that the size of the right atrium is being enlarged, where there is an atrialized portion of the right ventricle. The functional ventricle or the true functional ventricle usually lies anterior, and in most of the cases is dilated, and most of the function is related to the RVOT. So it's important to measure the functional right ventricle systolic function from MRI, as well as the size of the RVOT, whether it's dilated or not, because it is the RVOT doing most of the efforts for the functional right ventricle. There have been in literature some indices to measure from cardiac MRI. They have been measured or routinely measured from echo, but in MRI we could measure the same indices. So there are some prognostic indicators for the functions of the heart in Epstein anomalies, where you would be able to measure the total right side and in ratio to the total left side in the end diastolic volume. So you would measure the whole right side in relation or in ratio to the left, and those indices could be used as parameters to indicate the function rather than using the function of the functional right ventricle alone. Or sometimes they would there is other ratios that being described in the literature other than the total toward the total, but the measurements and all are being measured in the end diastolic volume. It's important to follow up those indices: volume of the functional right ventricle, function of the functional right ventricle, and the amount of the tricuspid regurgitation if possible. Usually the surgery, there is no cutoff values so far for the surgery. Clinical symptoms is more important and more relevant when to do the surgery, because the surgery is very invasive to correct the tricuspid regurgitation or the tricuspid leaflet, which is called the cone surgery. Most of those cases will come in MRI for follow-ups on a regular basis to follow up the volumes and the tricuspid regurgitation. So it's very important to that within every institute to have the same, or to follow up the patients in the same way that the base MRI or the first MRI was done, in order to provide accurate measurements. We talked about the distance, and we talked about the surgical operation and when they would describe the surgical operation. Many of these cases, of course, will be having arrhythmias, so sometimes it's difficult to get accurate measurements in MRI as a kind of limitation similar to any other modalities. We said the diagnosis, the functional assessment, and assessment of the tricuspid insufficiency or tricuspid regurgitation, and the follow-up pre and post-operative, of course, to see whenever there is any remodeling of the size of the right ventricle. Coarctation of the aorta, as you may know, that the coarctation, there are different types: pre-ductal and post-ductal coarctation. Anatomical, the description of the coarctation is the narrowing at the isthmus just behind the subclavian. This is the postductal type, but it could or might, there is a spectrum that might include the entire aortic arch, and it overlaps with the hypoplastic aortic arch in some way. But important points to comment on is the degree of the coarctation, whether it's severe or not severe. Cross-sectional imaging, whether MRI or CT, could provide accurate measurements of the diameter at the isthmus or at the narrowest point. But there are other parameters that we need to comment on during reporting rather than giving only the diameter of the coarctation. So the distance from the coarctation or the narrowest point to the subclavian is very important, because this will decide whether a stent, interventional percutaneous stent, could fit here without jailing the origin of the left subclavian. The size of the diameter of the aorta before the coarctation and after the coarctation will also decide the size of the stent, because good sizing will prevent post-operative or post-interventional complication, which is one of the complications, the migration of the stent due to mal-sizing before the intervention. Another important point is to detect or to mention whether there are multiple collaterals or not, so that during the follow-up we would comment on the size of the internal memories and collateral, so that if the patient is going or will undergo a surgery, then we need to tell whether there are multiple collaterals or hypertrophied collaterals. And on MRI, as a matter of fact, if we measure the flow in a normal subject, if we measure the flow, trans or through plane flow in the proximal descending and a descending and distal descending thoracic aorta, they should be more or less equal. The arterial flow through the bronchial arteries or the thoracic vertebral arteries is very minimal. So the through plane flow here in the proximal and descending should be equal in a normal subject. But in a coarctation, because of the collaterals, there is going to be a large difference. So the flow here will be much more than the flow at the distal part. This is due to that there are large amount of blood is shunting through the collaterals to join the descending thoracic aorta. And the treatment, of course, it will depend on the shape, whether there is any other congenital, any other associated congenital anomalies, on the shape and the size of the coarctation, how close is the subclavian artery to the coarctation, any kind of kinking that will prevent the stenting or the intervention and will send the patient to the surgery. Fallot will be the next presentation. Thank you.